Now, before we start talking about the heart, let's just think about how much work this organ does, sitting right here. You haven't probably given 1 nanoseconds thought to your heart beating, have you?
Yeah.
And you certainly don't control the beating of your heart. All right. But it has to keep beating to keep that blood in motion. And so let's just take some examples. If, at a nominal heart rate of 70 beats a minute, the heart beats about 100,000 times a day. Now, how much blood would a heart be pumping at that rate? Say 70 beats a minute, and say it's pumping 2 ounces of blood with each beat, about 60 milliliters. Over a 24-hour period, you could fill up a bunch of 55-gallon drums with that volume, beating at that rate in 24 hours. I mean, it's amazing, isn't it, when you think about it? So at 70 beats a minute, 60 milliliters per beat, you're going to fill up maybe close to 29 55-gallon drums. Now, if you increase the rate just up to 80 beats a minute, you could fill up almost 40 55-gallon drums. That is a lot of blood that little old heart is tirelessly pumping, minute after minute after minute. So we need to treat it well, don't we?
Yes.
All right. Now, the anatomy of the heart, we're going to kind of move through rapidly because we've already talked extensively about the anatomy of the heart. But one thing I wanted to show you is this thing about the pericardial sac. Now, you late lab folks, I will show you a heart with pericardium on it. But the heart grows into a space in the mediastinum that's lined with a serous membrane. And it pushes that membrane ahead of itself as it grows into that space. So as it pushes that membrane ahead of it, some of that membrane sticks to the outer wall of the heart. But the rest of the membrane doesn't stick to it because it's a smooth, slick membrane. It doesn't stick to itself. So you can think of it as a fist being pushed into a balloon. Let the fist be the heart and the balloon be the pericardium, and you're pushing into that, pushing into it. That part of that balloon is touching the heart, isn't it? All right? And that's what sticks to the heart. The rest of that balloon doesn't stick to the heart. That's what forms the sac. So when you look at this picture right here, here is the pericardial sac right here. And you see this turn right here? This membrane is the same as this membrane. It's just that when the heart grew into this space, it pushed this membrane ahead of it, which was out here. In other words, if you envision this being right here and the heart pushing in, you pushed it in like that. And so this membrane here, covering the heart, and the inside of this membrane right here, those are both serous membranes. So they're constantly secreting a little bit of serous fluid, or quite a bit, but they're also constantly reabsorbing most of it. So what we're left with is maybe 10 milliliters or so of serous fluid that is contained in the sac where the heart beats. So it reduces friction as the heart beats. That sac, as we will find out, does not fit real tight on the heart. It's kind of snug, but it's not real tight. Now, so this out here, this part right here is external. So this is connective tissue out here. So we have names for these things, for the parts of the pericardium. This part out here that's fibrous is fibrous pericardium. This is, connective tissue. This, as I said, is a serous membrane in here. It's the same membrane, but we give different names to the parts of it. The part that's covering the heart right here, we call visceral pericardium. The part that's forming the inside lining of the sac, we call serous pericardium. And the cavity is the space in between. So here's heart muscle itself, and now this is the inner lining of the heart, and this is a heart chamber right here. Now, visceral pericardium, visceral pericardium is also known as epicardium. So epicardium and visceral pericardium are the same thing. The heart has three walls: visceral pericardium, or epicardium. Three parts to its wall: visceral pericardium or epicardium, myocardium, and endocardium, which is a simple squamous epithelium that lines the heart and, in fact, lines all blood vessels. All right. So the rest of the anatomy we have been over. And we know now that whereas one red blood cell, starting in the inferior vena cava, would travel in a certain circuit to end up in the aorta, if it were just one red blood cell. But as a matter of fact, blood is moving through both sides of the heart at the same time. Therefore, we have two circuits: a pulmonary circuit and a systemic circuit that we've talked about. So the right ventricle is going to be pumping poorly oxygenated blood to the lungs to be reoxygenated. That blood's going to come back to the lungs, to the left atrium. So that's the pulmonary circuit. And it also includes the right atrium. All right? That freshly oxygenated blood then arrives back in the left atrium, passes to the left ventricle, and is pumped to all parts of the body. And so that's the systemic circuit down here. Now, as you may recall, I think in A&P1, the emphasis is on skeletal muscle, and probably don't talk too much about cardiac muscle or smooth muscle. But in A&P2, we talk a lot about cardiac muscle and smooth muscle. Cardiac muscle has some similarities to skeletal muscle. They both have sarcomeres. They both have sarcoplasmic reticulum. But, other than that, there are not a lot of similarities. Cardiac muscle tends to have one nucleus per muscle fiber. The fibers are not as long as some of those long skeletal muscle fibers. And they're not as tightly packed as skeletal muscle fibers. One of each of these.
Thank you.
Now, in skeletal muscle, most of the time we have an origin on bone and an insertion on bone, don't we? Or, in some cases, we have origin on bone and an insertion in a tendon-like material called an aponeurosis, like our abdominal muscles, for example. Well, in the heart, those muscle fibers...
I'm sorry. Can you speak up a little louder? We can't hear you. Yeah, it's hard to hear.
Oh, okay. Okay, I'll try. In the heart, those muscle fibers are connected to each other, and they pull on each other when the heart is contracting and pumping. So those fibers are connected to each other by intercalated discs, as you see these darker stained areas right here. You see the loose arrangement of the cardiac muscle fibers here, and usually a single nucleus per fiber. Now, you also, in cardiac muscle, you have some little buttons here called desmosomes, and they keep the fibers from twisting on each other. And you have many little openings between the fibers, connecting the fibers. These are called gap junctions. So they let ions and small molecules and electrical currents pass quickly from one fiber to another. So those are some differences between cardiac muscle and skeletal muscle. So to compare, skeletal muscle we know contracts voluntarily, does it not? What makes skeletal muscle contract? A cortical stimulus, right? A neural stimulus. Unless it's a spinal reflex arc, you know, or a cranial reflex arc, then it's, you know, not necessarily cortically controlled, but the cortex knows about it. But cardiac muscle, of course, is involuntary in its contraction, isn't it? You can't really control that. Now, skeletal muscle contracts intermittently. In other words, when you need a skeletal muscle to work, it'll work for you. All right. Cardiac muscle contracts continuously, obviously, but with rest periods between contractions. When you're using skeletal muscle, you don't, for any given muscle, you don't necessarily use all fibers in that muscle to do, you know, different tasks. A task that doesn't require much tension, you can use just a few of those fibers. If you want to create more tension, you use more fibers in that muscle. But the fibers, the skeletal muscle fibers that you are using are contracted fully and completely at the time. They're in complete tetany, the ones you're using. You may not be using all of them in a muscle, but the ones you're using will be in complete tetany. So that's what I'm telling you right here. Whereas over here in the heart, basically you've got a twitch, a muscle twitch, and then a rest. A muscle twitch, then a rest. And here's the complete tetany I was telling you about. But this is a very important feature of cardiac muscle right here. Cardiac muscle cannot be tetanized. And I'll show you why in a little bit. Now, skeletal muscles are fatigable, are they not? In other words, you can call on a skeletal muscle to do work for you until it is not capable of doing any more work. In other words, you fatigue it, you wear it out. You use up all the available ATP, and it's beyond the point, it's just going to stop working for you. But cardiac muscle is resistant to fatigue, and it has a lot to do with the fact that it's resting between beats, and it cannot be tetanized. All right, the internal anatomy of the heart we've already talked about. We don't need to go over any of that unless you have any questions about it. Fibrous skeleton we've talked about. Blood supply of the heart. We've talked about that. So we have two coronary arteries. Not everybody has exactly the same distribution of the branches of these arteries, but most of the time it's basically going to be the anatomy we've gone over in lab and what I have in your notes right there. You know, but different people's arteries are going to branch in slightly different ways. Now the venous drainage, you know, the heart has to supply itself with blood just like any other organ, doesn't it? It's got to have a blood supply. And we talked about that. That blood supply comes through the coronary arteries. Now, when does the heart get its blood supply?
It's resting.
When it's contracting or when it's relaxed between contractions?
Relaxed.
All right. And how does that happen? Pardon?
When the pressure comes back down.
The left ventricle pumps blood into the aorta and increases the pressure that's already in the aorta, because the aorta is not empty of blood, is it? Nor is the pulmonary trunk. And so when the ventricle rests before the next beat, that back pressure in the aorta closes the aortic valve to keep that blood from coming back into the left ventricle, which it just left from. And when it does, that pressure, that back pressure, squirts blood into the coronary arteries to feed the heart itself. while it's resting before it beats again. All right, and so this arterial blood that the heart supplies to itself has to drain back to the heart because it needs to be reoxygenated after each beat, right? And so most of that blood is going to eventually drain into that large vein on the undersurface, posterior inferior surface of the heart, the coronary sinus. Although there are a few anterior cardiac veins right here that drain directly into the right atrium. But most of these veins on the heart will eventually feed into that large vein, coronary sinus, on the back, and the coronary sinus is taking that venous blood to which chamber?
Left to the right, and left to the right, left to the right.
Which chamber is the coronary sinus returning
Right
its
atrium.
venous blood to?
Right atrium.
Right atrium. Okay? Because that blood goes from the right atrium to where?
Through the tricuspid to the right ventricle.
Right ventricle. And where is it going from there?
Through the pulmonary valve to the
It's
pulmonary
going
trunk.
to the lungs, isn't it?
Yes.
Be reoxygenated.
Yes.
Right. All right. Okay, let's talk a little bit about the heartbeat. Now, atrial and ventricular contraction are coordinated and in sequence. Okay? The atria and the ventricles do not contract at the same time. That should be obvious. All right? Now, we have two types of cardiac muscle fibers. Contracting fibers, which are most of them. And a few of them are specialized fibers called conducting fibers. So these make up the conducting system of the heart. These are specialized cardiac muscle fibers that make up the conducting system. Now, another thing that we will talk about, and probably repetitiously, is that the heart beats within itself. The heart generates its own beat. The beating of the heart originates within itself. Now, there are external factors that affect the rate at which the heart beats, but have nothing to do with origination of the heartbeat. The heartbeat originates within the heart's own conducting system. Things external to it that play on it, like the autonomic nervous system and various hormones, affect the rate, but not the origination of the beat. Now, so the conducting system of the heart is going to generate an electrical impulse which is going to stimulate the contracting fibers of the heart to do the work. All right, so the electrical event that results in cardiac muscle fiber contraction is called an action potential. So an action potential is an electrical event. It's followed by a mechanical event, contraction. Now, cardiac and skeletal muscle are similar in a number of respects, but they're significantly different in one particular one. And that has to do with the refractory period that I'm going to talk to you about. Now, before I talk to you about the cardiac action potential, let's back up a little bit and talk about action potential in skeletal muscle. You may remember this. All right, so in skeletal muscle, we have a neural stimulus that results in a muscle contraction and then the muscle's going to relax before it contracts again. Now, if you're using that skeletal muscle fiber, this is what's going to happen. You'll have repeated neural input that are going to continue to stimulate the muscle before it has a chance to rest completely. You can do this to skeletal muscle. You can build on those contractions. All right, so here, right here with just a simple single muscle twitch, the muscle relaxes completely. But here, the muscle doesn't relax completely. We've got another stimulus and we build on that one. Okay? So we're doing this. We've got what we call incomplete tetanus, but if the fibers in that skeletal muscle that we are using, I told you they're going to be completely on or off. This is what eventually we'll have. In other words, you've got that muscle in contraction and rapid firing of neural stimuli, keeping it in contraction. Remember your physiology from ANP1. And so this represents complete tetanus in skeletal muscle. The fibers in skeletal muscle that you're using will be in complete tetanus like this until you stop the stimulus, and then it will come back to here. But you notice cardiac muscle doesn't do this and cannot do it. And there's a reason. Now, let me get out of this. You got this in your notes here, but then we'll get back in that. Roll this up a little bit for us. Okay, get almost all of it in there. Now, what you're seeing up here is an action potential in ventricular muscle fibers of the heart. We won't go into a lot of detail, but down here we're measuring time in milliseconds, and up here we're measuring millivoltage in the cell membrane. Now, before we go to that, let's look right here at our skeletal muscle, comparing it with cardiac muscle. Here is an action potential in skeletal muscle, and followed by a skeletal muscle contraction. Down here is an action potential in cardiac muscle, and you see it looks a lot different, doesn't it, from the skeletal muscle. And there is the contraction that follows this action potential. All right? Now, let's go down here, look back up here, and we've blown up this down here to this. This happens in cardiac muscle because of movement of ions, sodium, calcium, and potassium through various channels in the membrane of the muscle fibers. Sodium and potassium and calcium move through what are known as voltage regulated gates. All right, so we're looking here at the resting membrane potential in cardiac muscle, and we're at minus 80 millivolts. Now, right here is the conducting system. I just put it as stimulus. Later I'm going to talk to you about the conducting system, but this right here, this stimulus right here, comes from the conducting fibers of the heart, the conducting system of the heart. This is what is known as a graded potential. A graded potential is one that conducts a current, but is not strong enough to be an action potential, but it causes action potentials. So this current here, as it rises, we're going to find out that the conducting fibers of the heart cannot maintain a stable resting membrane potential, so they always want to rise toward this. They can't maintain a stable membrane potential. They're down here and they want to rise. And when they do, when we get from here, when we get to here, those sodium gates open. And sodium, positively charged ions, floods into the cell, into the interior of the cell. Since those are positive charges, we're changing the voltage from a minus to a positive state. When we get up to about plus 30 millivolts, the calcium gates open. Now, remember in skeletal muscle, all the calcium is in reservoirs inside the muscle fibers in the sarcoplasmic reticulum. In cardiac muscle fibers, get one of each. In cardiac muscle fibers, calcium enters from external to the cell. So the first calcium comes from external to the cardiac fibers, and that calcium entering then causes those reservoirs in the cardiac muscle fibers, the sarcoplasmic reticula, to open and release more calcium. So calcium is the trigger of contraction, isn't it?
Yes.
For muscle in general, whether it's skeletal, cardiac, or smooth. Calcium is the trigger. All right? Oh. Okay. Now, so as long as calcium is being released right here, the fibers are going to be in contraction, aren't they? Right? Now, as long as you've got this going on right here at this millivoltage, by the way, those calcium gates close when it gets to plus 30. As long as you've got this going on right here, the cardiac muscle fibers are contracting, aren't they? Now, look at this space below the plateau, right here. This white space. This is called the absolute refractory period. A refractory period is the period during which a muscle fiber cannot be stimulated to contract again. Absolute means absolute. It doesn't happen. This is why cardiac muscle cannot be tetanized. All right? But after a point now, the membrane potential is changing, and so we're dropping off. And as we drop off, the potassium gates open. Potassium is a positively charged ion, just like sodium, isn't it? And so potassium leaves the cell. Remember, potassium has a greater concentration inside cells than outside cells. Sodium has a greater concentration outside than inside. So potassium leaves the cell. And now we've got positive charges back out here that are restoring the membrane potential that we started with right here before the next beat. Now, right here in this shaded area, we have what is known as a relative refractory period. This means that the muscle fiber can be stimulated to contract during this period if the stimulus is strong enough. So if we have strong autonomic, like sympathetic input, or even parasympathetic input, which would actually slow it, but hormones like epinephrine, norepinephrine, and so forth, the muscle can be stimulated to contract here, which would mean an increase in the rate, wouldn't it? But now, look at the time we're talking about here. Is this muscle fiber going to squeeze down and be squeezed down for a long time before it relaxes? We're talking milliseconds here, aren't we? So what is this?
2/10 of a
200
second.
milliseconds. What's that?
2/10 of a
That's
second.
2/10 of a second,
Yeah.
isn't it? All right. So this is the action potential in cardiac muscle. And to repeat the point, this is why cardiac muscle cannot be tetanized. And it's a good thing. because if it could, we wouldn't be here now. Now, all of this text over here, you can read later if you want to. It just tells you what I just told you. All right, so let's do a little review here. The actual mechanics of cardiac and skeletal muscle contraction are similar in some respects, but different in certain respects. Okay, so cardiac muscle is paced internally, skeletal muscle is paced externally. Cardiac muscle contraction is basically a twitch, then a rest, a twitch and a rest, a twitch and a rest. Continue. Cardiac muscle contracts in an all or none fashion. Not so with skeletal muscle. Now, the fibers in a skeletal muscle that you're using are incomplete tetany, as I mentioned. But for a given task, you don't necessarily have to use all the muscle fibers in a given muscle. It just depends on what you're doing. All right, and finally then, cardiac muscle refractive period is longer. And that's a major difference from skeletal muscle, as we just discussed. All right, now, going on to the conducting system. We'll be looking at the conducting system of the heart in the lab, but we'll initiate that now. So, what makes up the conducting system in a heart? Specialized cardiac muscle fibers, about 1% of the total mass of them. Now, the conducting system originates up here, high in the wall of the right atrium. This is called the sinoatrial node, often referred to as the SA node. All right, that current originates right here and spreads through both atria, through internodal pathways, and converges on this point right here. This is the atrioventricular node. It also is in the right atrium. It's down low in the interatrial septum. From there, it spreads into the interventricular septum, where it divides into two branches, a right bundle branch and a left bundle branch, which continue down to the apex and turn up into the walls of the two ventricles as the Purkinje fibers, right here. Okay, so that's the conducting system. Now, as I mentioned earlier, an important characteristic of cardiac conducting fibers is that they cannot maintain a stable resting potential. This is what stimulates the heart to beat over and over and over and over, because the conducting system generates a graded potential which causes the action potentials, which result in the contraction of the contracting fibers. Now, different places in this conducting system can originate the heartbeat. The normal place where it originates is in the SA node. And the normal rate of firing from there is 80 to 100 beats per minute. Now, does this mean that everybody's heart rate is going to be within 80 to 100 beats per minute? No. Why not? If the beat originates right here, how come everybody's heart rate is not somewhere between 80 and 100?
Some people have more blood that they've got to pump through their veins because of blockages and things? Okay. No.
Yes, because there are other factors that play on the heart. The autonomic nervous system, for example. Sympathetic stimulation increases the heart rate, doesn't it? Parasympathetic stimulation reduces the heart rate. certain hormones increase the heart rate. Norepinephrine, epinephrine, thyroid hormone. Certain drugs increase the heart rate. You know, caffeine will increase the heart rate. Cocaine increases the heart rate. Atropine slows the heart rate. Atropine is an anticholinergic drug. It's a cholinergic drug. All right, now, what if something is wrong with the SA node and it doesn't work the way it should? Do we have a backup?
Yeah.
Yeah, right down here, the AV node. So, looking back at this, if our SA node is sick for some reason, we can originate the heartbeat from here. I showed you this on an ECG, I think. Well, did I show you? Well, I'll show you later. Anyway, so we can originate heartbeat here, but it'll be slower. It'll be slower. Now, actually, the Purkinje fibers can generate the beat too, but look how slow that is. I tell you, if a person is having to depend on the Purkinje fibers to initiate the heartbeat, this person is in a very bad way. Very sick.
So the Purkinje is a backup from the AV?
Well, it's not, I mean, it can happen, but this is not normal. I mean, if this happens, you've got a diseased heart in some way. You've got a damaged or diseased heart. Because normally this is the place that the heart fires from. But again, the firing rate is 80 to 100. But that firing rate is constantly adjusted by what's going on in our lives at the time. All right, so autonomic input, hormonal input, various chemicals, that are injected that we take orally, whatever, that is going to adjust the heart rate. So again, neural and hormonal stimulation of the heart affect the rate, they affect the beat, but they have nothing to do with the origination of the beat. The beat originates within itself, within the heart itself. Now, this is more of what I was talking to you about, in that cardiac conducting fibers cannot maintain a stable, resting membrane potential. And so, because of that, the fact that they want to constantly rise from a more negative to a less negative state is going to result in the action potentials that we just saw. So here is the cardiac conducting fibers. This is what's called a pacemaker potential. This doesn't do the work of the heart. This electrical stimulation here results in work by the heart, by the contracting fibers. So you see, we're here at minus 60. It's wanting to rise to here. When it gets to here, we stimulate an action potential, and then our muscle contraction will follow that. And that's what this is telling you right here. Again, the point here is that the membrane potential for the conducting system is never a flat line. It can't maintain a stable, resting membrane potential. It's always moving. It's always moving like this. Again, we have things that influence the heart rate but don't result in the initiation of the heartbeat. Here's just a diagrammatic representation of the autonomic nervous system, showing you that there's both sympathetic and parasympathetic input on the heart. Again, here is our pacemaker potential, and this is showing you the autonomic effect on the heart rate. In other words, sympathetic stimulation will speed this up. I don't have a slide that shows this, but if we increase sympathetic discharge on the heart, what happens here is the slope of this pacemaker potential becomes more acute. In other words, it's rising from here to here faster. You follow me? And if we do this to these potentials, we increase the heart rate, don't we? If we've got parasympathetic input, for example, what we would do here is we would make it more obtuse. And so if we start here, it wouldn't create an action potential until they got over here. And so the heart rate will be slower. All right. Electrocardiogram is simply a graphical recording of electrical events in the heart. That's all it is. But we can learn a lot from an electrocardiogram. So ECG is the abbreviation for electrocardiogram. Sometimes you'll hear it called an EKG. That's because in German, cardio, the C is replaced with a K. So cardio in German is K-A-R-D-I-O. That's where the EKG came from. So it's simply a graphical recording of electrical events in the heart. Now here is part of a tracing. You're going to be doing this in lab. You're going to be doing ECG tracings in lab.
Awesome.
But this is just a piece of one. So let's look at this as representative of what's going on in the heart. Now, here was our conducting system, wasn't it? It started in the SA node, through both atria, converging on the AV node, into the bundle, into the
intraventricular
interventricular septum as the
septum.
bundle branches, and then as the Purkinje fibers down. All right? Now, so let's say that we got a normal heart, and the heartbeat is originating right here in the SA node. All right? The firing of the SA node is going to create this deflection on the tracing. This is called the P wave. The P wave. Now, again, this tracing here is representing electrical events in the heart. It's not showing you anything about the conduction, the muscle contraction. I didn't mean to say conduction. It's not showing anything about the muscle contraction in the heart. This is just the electrical events. So, atrial depolarization refers to firing from the SA node, creating a current, a graded potential, that's ultimately going to cause atrial contraction, muscle contraction in the atria. So atrial depolarization is the electrical event, which is followed by atrial contraction, which if we drew it in would be right here, but it's not showing on an ECG. All right? Then we have a short interval right here where we're back to the baseline, basically. Now, so we get this right before we come to this big deflection right here. What's happening right here? Well, I didn't tell you before, but that I recall, but we're at the AV node now. We're at the AV node right here. Now, there is a slight delay at the AV node, about 1/10 of a second, in order to allow the atria to fully contract and empty themselves of blood. In other words, to empty their blood into their respective ventricles. So the conducting current pauses for 100 milliseconds, 1/10 of a second, to let the atria finish contracting. All right? So now we have this big deflection, which is called the QRS complex. This, now we're down in here. we're down in the ventricles. This right here represents ventricular depolarization, electrical event. What mechanical event follows this? Ventricular contraction. You with me?
Yeah.
All right, so this is the QRS complex. Then we have a little isoelectric line right here, little pause, before we have this deflection. This is the T wave. This represents ventricular repolarization. And now if we follow this on over, we'd be back here, and we'd be starting another. Now, this is the way this works. Let's follow it through and show you what's happening in the chambers with each part of the ECG. All right, so we're at the SA node, that fires, and here's the P wave. Now, notice that the current is beginning to spread to both atria. And yellow is representing depolarization, red is repolarization. See our key right up here. Now, it's passed through the internodal pathways to both atria. And we're now down at the AV node, which is represented by this little part right here. Now that conducting current passes on down in the interventricular septum through the bundle branches and into the apex, and now we get this QRS complex. Now it's fully complete, and both ventricles are fully depolarized, and muscle contraction is going to follow this. Now, once fully depolarized, we have this little isoelectric pause right here before the ventricles begin to repolarize with this T wave, which you see in red right here. And now the ventricles are fully repolarized and ready to start here again. Now, you also notice right here that as we go from here to here, the atria are repolarizing, aren't they?
Yeah.
But did we have anything on the ECG that showed atrial repolarization? No. We see atrial depolarization, but we don't see any deflection in here that represents atrial repolarization. But it's happening, as we see right here, isn't it? So why don't we see it here? It's because it's hidden in this QRS complex. So this is so powerful here that it masks the deflection that would occur for atrial repolarization.
So the atrial repolarization hides
It
the
happens,
QRS complex.
but you don't see the electrical event.
Okay.
You don't see it in the recording.
Okay.
It's happening inside here.
Okay.
All right, so let's review. Atrial depolarization is represented by the P wave. It's followed by atrial contraction, the mechanical event. Ventricular depolarization is represented by the QRS complex. It's followed by the mechanical event, ventricular contraction. Ventricular repolarization is the T wave. It occurs as the ventricles relax. All right. Now, atrial repolarization would be happening in here on the tracing, but it's overshadowed by the QRS complex. It's hidden inside the QRS complex. Now, here are some examples. You have a question?
Just a quick one. The picture you showed us where it actually shows you, that one, is that figure 18.17 or 18.18 by any chance? Or do we not have that in our book?
It should be in your book,
Okay.
I think.
Okay.
Is there a reference to something in your notes?
I do see a couple, I just wasn't sure which one it
Well, if
was.
you got a reference, it's in your book.
Perfect.
Textbook.
Okay,
Any annotations about figures and charts and diagrams in your lecture notes refer to your textbook.
excellent, thank you.
All right. Now, here are some examples. So let's look at these examples. Let's start up here. This is a normal one aspect of an ECG. You know, when you do an ECG, you do limb leads and chest leads. In other words, a standard ECG is about 12 different leads. So we're just looking at one lead. It's probably a limb lead. It's probably lead 2 because all the deflections are positive, which helps us to understand it better. Because on a full ECG, not all the deflections are upright. Some of them are downward. But anyway, can we see P waves on here? Here's a P wave, right? And a little pause, and then a QRS, and then a T wave. Then a P, QRS, T, P, QRS, T. So, repeating in a rhythmic pattern that's regular, right? So we would call this a normal sinus rhythm or regular sinus rhythm. If you've seen some doctors' progress notes in the chart, or for history and physical, and for the heart, they'll say NSR, normal sinus rhythm. It's just abbreviation for it. So this is a normal sinus rhythm. What do we mean by sinus rhythm?
Because it's the,
It's coming from the SA note. All right, so it's a normal sinus rhythm. All right, now, let's look at this one. Now, what do you notice right away about the rate here?
it's real slow.
This looks slower, doesn't
Yeah.
it? This looks slower. It is slower. All right, now, let's work through it. P, Q, R, S, T. I don't see any P values. Do you? This is the QRS, isn't it? This would be a T. We should have a P right here, shouldn't we? It's not here. What I tell you happens if the SA node is not
The AV, and that's why it's slower.
normal. We
Okay,
drop down to the AV node.
yep,
And since we're at the AV node,
you don't get that.
we don't have a P wave,
Yep.
do we? So this is what's called a junctional rhythm, meaning it's at the AV junction. All right, so it's going to be slower, isn't it? Because the natural firing rate of the SA node, the AV node, is slower than the SA node. Okay. All right, now this one here. Let's see if we can look through here. All right. Here is a P wave right here, a QRS, a T. Now we've got another bump right here. What is that? But it's probably, I'd say it's a P wave, but it's not followed by a QRS. However, there's another P wave right here. Now we got a QRS and a T, P, P, QRS, T, P, P, QRS. What do we got here? There's some kind of blockage in the conduction of this current here, isn't it? So we've got more P's than we've got QRS's, haven't we? So this is a type of heart block. So this, for example, is a type of 2-to-1 heart block, which means you got 2 P's for every QRS.
Why does the QRS go down so much lower?
And what?
Why does the QRS appear to go down so much lower?
Yeah, it dips down.
Dips down further.
It could be a different person, a different lead.
Okay.
That doesn't matter.
Okay,
This is the more natural way that the QRS looks anyway.
okay.
All right, so we're firing from the SA node, but not every one gets through. So we're dropping some QRSs. There are various kinds of second-degree heart block. In fact, there are various kinds of heart block. You can have a first degree, second degree, third degree. A first degree may be only an increased interval between the P and the QRS. The normal distance from the start of the P to the QRS is 0.2 seconds. So if you get beyond 0.2, you're getting into the first degree heart block. That's usually not much, but it could indicate, some problem. Then there are various types of 2-to-1 heart block. When you get to 3-to-1 heart block, you have got a serious delay in conduction of that current. And that can cause some serious problems. People can lose consciousness over this. They fall, hurt themselves. They lose consciousness because there's
They're
no
getting the
blood
oxygen.
flowing to the brain,
Yeah.
as fast as it should be. All right, now, what about this one?
That's
Is
crazy.
there any kind of order at all to this tracing? No. You can't read anything into that. It's totally chaotic. This is fibrillation. This is actually ventricular fibrillation. So what happens as a result of this, because there is no coordinated conducting current, those muscle fibers are being stimulated from multiple sources, and the muscle fibers in the heart are doing this, like a bag of worms,
Okay.
instead of doing this. This results in ineffectual contraction of the heart. This is death, unless it's converted.
And that's when a defibrillator would be used?
Yes, you would use a defibrillator, something like
And when
that.
you use a defibrillator, what is it actually doing? I mean, I've heard people say it stops the heart, or what is it? It's setting a current.
It sends a current to the heart to try to restore the natural conducting rhythm of the heart, conducting
Would a
circuit.
pacemaker be put in to control that?
No, not to control this.
I mean, because my dad was a pacemaker.
Well, there are various reasons to put in a pacemaker, but a pacemaker, for example, would be indicated in somebody with a third-degree heart block, because the heart's not beating rhythmically fast enough. So the pacemaker, if the heart is not doing it, the pacemaker will trip the heart and send a current through. That's a classic use of a pacemaker.
They actually have don't they actually have the defibrillator they put in that actually does that too?
Internal defibrillator?
That's it, yes.
Yes, they have some internal defibrillators now. Some patients will have those, heart patients.
Okay.
All right, we'll stop here, and we'll start with the cardiac cycle now.